All right, so I don't know how we're going to review both tests. I'm open to suggestions, but if you want, we can look at one of them after class today, maybe the anatomy, and tomorrow do the physiology. But I'm open to suggestions. In any case, if you want to do that, I'll just remind me because I'll probably be oblivious as usual. All right, I think in the anatomy, we are talking about the abdominal cavity. We left off talking about the stomach. We're going to talk a little bit about GI tract physiology. I may need to modify that unit before we get to it. But in any case, we're looking at the overall structure, the overall anatomy of the abdomen here, and a couple of things we probably should appreciate. The slide here is titled Esophageal Sphincters. Traditionally, there are two esophageal sphincters. There's the isthmus, oropharyngeal isthmus back here. Remember we talked about that earlier. That forms the upper esophageal sphincter, and there are all kinds of things that can go wrong there. And then we're looking here at the LES, the lower esophageal sphincter. This is going to be important, an important region for your consideration to the extent that this is the site of gastroesophageal reflux. So it's really backflow that is more of a problem with the LES than regulation of influx into the stomach. And any number of things can happen. We'll have a couple of slides coming up where we look at the histological change, the important histological change that occurs at the mucosa in this region. But if this sphincter, and of course we've defined what a sphincter is, a valve-like structure, smooth muscle structure, if that sphincter ceases to function properly, not only does reflux make its way into the esophagus, but that can dramatically change the mucosa of the lower esophagus, in some cases even intermediate regions of the esophagus. And by itself, that's not a problem, Barrett's esophagus and so on, but it can dramatically increase the risk of esophageal cancer, for example. So those histological changes are, in addition to the other problems, everything from voice changes to heartburn and pain and so on, can be accompanied by substantive increases in critical disease risk. As I say, we'll come back and talk, we'll have a better picture of the Z line. The other thing I would note about the esophagus, I think we mentioned this before, remember at the UES, the esophageal muscle is primarily skeletal muscle. And in fact, if you look at a histological transection, that is why you have voluntary control over the initiation of swallowing, but it's very hard to undo a swallow once initiated. And that's because as the esophagus continues distally or inferiorly, that skeletal muscle is displaced by smooth muscle, such that by the time we get to the LES, all of that sphincter is smooth muscle. So we can see the relationship of the, we can see this proportion of the esophagus here to the stomach. The only thing that I would point out, because this image is so small, we'll talk about the laminar organization of the GI tract a little later. But the only thing I would point out about the esophagus, we've indicated before, it's normally closed. Unlike the trachea, it's not normally patent. And in fact, there are several points you will learn in your clinical coursework, several points where it's vulnerable to issues and problems because of compression from surrounding structures. Now, this is the gastroesophageal or esophageal-gastral junction. And we'll talk about some of the anatomical features here. But what you'll notice here is this little line located right there. And that's called the Z line. And that Z line represents a rather abrupt, I'm not sure why I didn't include the picture here, perhaps it'll be in the physiology, a rather abrupt change in the epithelium from predominantly stratified squamous to simple columnar. And it's not a gradual change, it happens very, very suddenly there. Of course, that arguably is to facilitate the very different functions of those tissues. Anatomically, again, we'll have a better picture of this, so I think I'll just defer that. We have some regions here we need to talk about, but I think we'll defer that until we look at those images. But we mentioned that the stomach, now that we're down to the stomach, is primarily a storage tank. It's not so important for digestion. It's not so important for absorption of nutrients, although it has limited ability to do both. You get liquored up weekends like I do, and a substantial portion of the alcohol is taken in to the stomach. But by and large, it's a storage tank, and it has the ability, as we're going to find later, to, unlike your lungs, we were talking about physiology, when the stomach expands, intragastric pressure should not increase. That is to say, the wall of the stomach is not very elastic, and there are a number of other mechanisms. We need to talk about the wall of the stomach a little more later. But my point is, the stomach has the ability to change volume dramatically without a corresponding change in intragastric pressure. You can imagine how difficult feeding and eating might be if intergastric pressure increased as you drank or increased the volume of food that you ate. So with respect to the general functions for anatomical purposes, the stomach is chiefly a storage tank. Ingesta, which is taken into the mouth, into the buccal cavity, passing through the esophagus and delivered to the stomach. We then have a special name for that stuff in the stomach. It's now called chyme, C-H-Y-M-E. So whatever food you ate, whatever stuff you drank and mixed together, by the time it gets to the stomach, we just put it all together and call it chyme. So in both courses, chyme is the ingested or food that's taken into the GI tract once it enters the stomach. Now, there is some limited digestion going on in the stomach. Of course, the stomach is a highly corrosive, the interior of the stomach has a highly corrosive environment, very low pH. But the only enzymes that are really present in relative abundance here are proteases, which begin the breakdown of protein, dietary protein. But even there, only about 20% of the dietary protein is digested. Now, the other critical point we'll talk about more in the physiology as time permits is that as the stomach acts as a storage tank, its primary function, I suppose, we could argue, I think, is to release into the intestine, the small intestine, the duodenum here, chyme at a precisely regulated rate, a rate appropriate to optimize or maximize the breakdown and assimilation of nutrients into the blood. So in part what the stomach is doing is just holding the chyme back until the duodenum and proximal intestine is able to take advantage of that food. You might imagine, for example, what would happen if this very acidic abdominal chyme were suddenly released into the duodenum. That could cause a number of problems, dramatically dropping the pH, perhaps increasing the risk of intestinal ulceration and so on. So we'll talk about the factors that are important for passage of chyme from the stomach into the intestine by means of this gastroduodenal junction. We talked about the omentum. I have a little video coming up later in which the omentum is actually removed as part of a surgical process. I hope it's on this. I didn't have a chance to check if we're on this set of slides or not. But that's called an omenectomy. You thought an omenectomy was no longer watching omen movies, but this is an omenectomy in which the omentum is removed. We've talked about the greater and the lesser omentum. We've talked about the proper terms. For example, we indicated that there might be an extension between the liver and the stomach, the hepatogastric ligament, hepatoduodenal ligament. So be familiar with those terms as well. All right, here's a little image we can use to talk about the anatomy of the stomach. You should be familiar with the general regions, the general organization of the stomach. So you can see the esophagus, and make sure you understand that for the most part, in a normal individual, the stomach is sort of disproportionately positioned to the left side of the midline. The esophagus, therefore, is descending to the left, sort of anteriorly and to the left. And there's a region where the esophagus meets the stomach called the cardial or cardiac. Just about every source has a different spelling, but be aware that you will see both terms referring to the same thing. So when we talk about the cardiac or the cardial stomach, we're actually talking about the distal esophagus, where the distal esophagus joins up with the stomach right here. And you can see superior to that is the cardiac or cardial notch. And anybody know why it's called the cardiac region of the stomach?
Where the apex is.
It's not that close to the heart,
No.
frankly. It's a bit of a mystery. It's a good ways from the heart. There are cardiac glands in this region, but then that brings up the question, why are these called cardiac glands? I guess because that's where the cardial part of the stomach is, right? Presumably they're named after the proximity. This is the region of the stomach that's closest to the heart, but in any case, those cardiac glands in this region, right in here, chiefly secrete mucus. So that's the cardiac region. The most superior portion of the stomach is called the fundus. And basically, everything superior to the esophagogastric junction is called the fundus. Most of the stomach consists of the body. You'll notice the interior of the body is characterized by the presence of these convolutions called rugae. And so those are all, rugae is the plural, R-U-G-A-E. I think the way I write is probably more mystifying if I just don't even write it, right? It's hard to read my writing. But these are the rugae, the little convolutions that you see there, and they contribute to the ability of the stomach to change its volume receptively without an increase in intragastric tension. Now, the problem we're going to have, that you're going to have in discussing the distal stomach, is there's just an enormous variety of terms used to describe this region. The first point I would make, and you probably have already encountered this in your radiology class, is that the distal stomach is very hard to differentiate from the proximal intestine most of the time. In fact, most of the time they're about the same size, about the same radius. Very rarely in radiological imaging do you actually have a large caloric region and then a small duodenum. More often it looks like just a continuous, fairly narrow tube. So that's one problem you're going to have. But this distal region goes by a variety of names, and we're going to use them interchangeably and not worry too much about the details. This region is called the antral region of the stomach. Antral region. It's also called the caloric region. And the key thing to keep in mind here about this region of the stomach, if this region up here is chiefly for storage, most of the churning, most of the motility, most of the abdominal motility occurs down here. You can sort of imagine this as a little gyre, an ocean gyre or something, and as the chyme of various size, and you might have had a steak, right? You mechanically reduce the steak by means of your dentition, your teeth, but there's still pretty good morsels of steak in there. Well, not all of those large morsels will fit through this caloric canal or sphincter here. Consequently, the stomach, they'll just keep churning back and forth until the enzymes and the low pH has had a chance to work on the stomach, and then those morsels, those portions of the chyme, will gradually be admitted into the duodenum. The larger point here is this region is the region of increased motility, hypermotility relative to the storage area back here. So be aware of that terminology. This region right here also goes by a variety of names, but for the most part, I think in the anatomy we'll call this the pyloric sphincter. But again, our big emphasis in here is on physiological function. So for the most part, I'm going to call this the gastroduodenal junction, because that sort of emphasizes its function. The stomach, I guess the last point I would make with respect to the general anatomy of the stomach is that unlike other regions of the GI tract, where the muscular wall consists of two layers, and I think we mentioned this before, for most of the GI tract, there's a radial layer, there's a layer of smooth muscle that goes circumferentially around the lumen. And then there's a layer that runs lengthwise exterior to that. In the stomach, there are actually three layers. There's a radial, longitudinal, and then there's a more interior transverse layer. So the stomach is a bit unusual in that there are three layers of what is called muscularis externa. So you have several illustrations of these regions, and all of them have slightly different terminology. Also be aware of what is called the greater curvature relative to the lesser curvature. The lesser curvature is sort of concave on the right side, and the greater curvature is convex on the left side. Otherwise, I think we've talked about the important components. You can see the pyloric sphincter and the antral region, the pyloric orifice, as rendered in a cadaver in these images. So be able to recognize. I'm not too concerned about your ability to differentiate the canal from the orifice, but you certainly need to be able to be aware of what we mean by the pyloric or antral region of the stomach, differentiate that from the cardiac esophagus or stomach and the fundus and so on. Now, we've talked about the blood supply to this region. In fact, we saw this earlier as well. What we're looking at here, of course, is the stomach, and then we can see the celiac trunk here. And that celiac trunk, as you recall, gives rise to the common hepatic artery. Well, there's some other arteries we'll talk about in just a moment. But it also gives rise to the gastric arteries, either directly or indirectly. So we're looking here. Let me see if I can change the color of this to make it blue. So this is the gastric artery there. That's the right gastric artery. And then you can see that there's going to be a gastroepiploic artery down here. And then what is not very clear is that there are similarly named, here's the splenic artery. There are similarly named arteries over here that arise from that splenic artery. But I think for our purposes, just be aware that most of the blood supply to the stomach arises from the celiac trunk directly or from branches of the splenic artery, which also arises from the celiac trunk. And in general, those arteries have one of two names. They're either gastro-omental or gastric. And there's right and left for each. And we've already indicated that gastro-omental and gastroepiploic are used interchangeably. And you have several illustrations here. Here's the right gastro-omental epiploic, left up here. Right and left gastric arteries. Kind of hard to see these sometimes in the cadaver images. You sort of have to get your bearing. Generally, if I would show you, ask you to identify a cadaver image such as this, the image would be large enough. I noticed some of you, when you take your captures for the Acklin, make sure you take a capture that's large enough that you can get the context. If you just have a big tube that are looking at you, sometimes it's hard to know what that tube is, so make sure you have enough in your capture for study purposes that you can see the entire context of the structures. But otherwise, you're very familiar with the superior mesenteric artery, inferior. We can see that we're going to be talking about the radiations of these inferior mesenterics, but of course the inferior mesenteric is important because it supplies the intestines, and of course those branches are radiating through the intestinal mesentery, that sort of specialized peritoneum that we talked about. Venous drainage, the terms are the same, but of course the anatomy is a little different as we saw before. Remember, this is the superior mesenteric vein, inferior mesenteric vein over here, and then we have that large portal vein and the splenic vein connecting the two behind the stomach there. So the drainage for the stomach is primarily into the celiac superior and superior mesenteric. Portion of it's going to go especially from the left gastric vein and the left epiploic into the splenic vein and then back into the either the superior mesenteric or the portal. And bear in mind, as we indicated when we talked about the arteries, there's considerable variation. You shouldn't expect all patients to have this organizational arrangement of the veins and the gastric around the stomach, gastric region. All right, so we've already talked about these structures. We're going to come back and talk about the hepatic portal vein a little later as we talk about the portal triad. You already know pretty much the nature of autonomic innervation and the function of the branches of the ANS to the GI tract. So over here, of course, these are the sympathetic trunks. You're very familiar with those in this region. You already know how the anatomy of the preganglionics and the postganglionics and structures below the diaphragm. You know we're talking about prevertebral ganglia. And then here are our vagus nerves. Now notice at this point, as we descend, the vagus nerves are running alongside the esophagus at this point, and along virtually the entirety of the esophagus, but especially distally, they sort of break out into what is called an esophageal plexus. So you're looking at the esophageal plexus here. And the esophageal plexus is chiefly parasympathetic, but in reality, there is just a confusion of wires in here between the sympathetic and parasympathetic. But at the very least, you should know the origin of the postganglionic cells that we talked about previously. And of course, with respect to function, you know that the parasympathetic, the vagal stimulus is largely upregulation of digestive tract activity. Sympathetic, with a few exceptions, is going to suppress GI tract activity. We'll talk more about that later. There's some other interesting facts. If we have time, we'll talk about with respect to these pathways too. For example, did you know that the bacteria in your intestine influence your behavior? And you may have kept up with this, not only influence your behavior, but have a potentially dramatic effect on your health. But the question is, how would bacteria, as you look at this anatomy, how would bacteria in the stomach, not so much in the stomach, but in the intestine, and especially in the colon, influence your behavior? What is the, how are they getting a signal to the brain? All right, so you're suggesting some type of hormonal interaction, chemicals that are released into the blood, right? Yeah, that's always been the predominant hypothesis when this was first discovered. But the curious thing is, at least in rodent models, and I don't know how many of you feel that you have a deep abiding affinity with a mouse or a rat, but when you cut, especially the parasympathetic pathways, a lot of that, and we'll talk more about this later, but a lot of those responses, a lot of those signals from the bacteria disappear. So we don't quite know how that happens, except that at least in rodents, the parasympathetic pathways seem to be very important. Yeah?
Would you say that the esophageal plexus is chiefly parasympathetic or sympathetic?
The esophageal plexus is, again, when we get into the plexuses, it's really not a very important distinction because, especially as we move south, these are sympathetic. These are your sympathetic trunks. These are the vagus coming down chiefly parasympathetic. Yeah. I'll certainly grant you that as we move south and we get into the hypogastric plexus, the distinction is quite meaningless. All right, so here I thought we'd take a moment to look at a very brief video. This is robotic surgery for an abdominal tumor. And not only does this illustrate some of the amazing new technology, we saw the robotic device earlier in animation. But here they're going to remove a tumor. And I don't know, because a lot of times I have to look at these videos several times to figure out what's going on. But in general, what you're going to do is just staple away the defective or the portion with the tumor. And so it's removed in that fashion. But of course, the fellow's sitting away looking at the large screen. He's using his fingers to manipulate the device. The other interesting thing here, of course, this is a tumor. This is a cancer. And this procedure also involves an omenectomy we talked about before. The greater omentum is being removed. And I think the current thinking is that the omentum probably does a lot of things that we didn't previously credited it with. For example, it probably has an immunological function, it probably has an endocrine function. We're learning something about that, but in general, there don't seem to be too many side effects. In any case, the point I'm trying to make here, is that it's often a vector for cancer cells. And so as of any time, I won't say any time, but often when there's a stomach tumor, that will be removed simply as a prophylactic measure to reduce the risk of the tumor being the cancer spreading. I don't think there's any audio for this. I can hum for you if you wish. So we're seeing the tumor from the inside. That's about the only really good view we have of it. That old CRT isn't very comforting, is it? This is in India, I think, by the way, this is. And there's the fellow back there. Oh, there's some audio. So the tumor is in the fundus. You should know where the fundus is superiorly. So they're removing the omentum for the reason that I suggested. As far as I know, that's the reason they're doing it. Cauterizing some of the vessels that might expose it to bleeding. And then watch the procedure used to isolate and remove the tumor. I guess that's the tumor. Nothing much those people can do. It's all in the hands of this fellow right here. Quite literally. Whoa. And there we go.
Oh, just like that.
So you can see they stapled off a portion of it there.
What? That's awesome.
And so now that portion has been entirely isolated from the main body of the stomach. And all that's left is to remove it. It's like a little insect larvae.
It does.
You wouldn't laugh if you had those like I do. I have to scrape them. So there you go. There's the insect larvae. So it's quite remarkable, all achieved with a little robotic device there. Hi. All right, so let's move on to the intestine. So as you know, the intestine consists of three components: the duodenum, the jejunum, and the ileum. The duodenum is the shortest. In fact, the name duodenum means 12 fingers. I suppose 12 fingers refers to the width of the fingers, but it's about a foot long in most people. So it's very, very short, but it's the most important region, arguably, simply because most of the digestion and absorption occurs in the proximal intestine, in the duodenum, and to a lesser extent in the proximal jejunum. Anatomically, we're also going to find that the bulk of the digestive enzymes, the pancreatic juice, the bile is all delivered into the duodenum. So for those reasons alone, it's a very, very critical region. You can see it in the cadaver specimen here. Sort of has the conformation of a Ford radiator hose. And technically there are 5 parts. We won't worry too much about the traditional segmentation of the duodenum, but what I do want you to notice is that this part C here, this sometimes depending upon the authorities, either the second or third part, is the descending duodenum, And you want to know that the descending duodenum is where all those goodies I just talked about are delivered. So, for example, pancreatic juice is going to be delivered here. The bile is going to be delivered into that region. And they contain the digestive enzymes and some other components we'll talk about later. The other thing I think to keep in mind is that only the initial duodenum is peritoneal. Most of the rest of it is outside the peritoneum. And so you can see the duodenum here and the cadaver preparation. There is no frank, no abrupt junction between the duodenum and the jejunum, or the jejunum and the ileum. There is nothing comparable to the Z line that we saw between the esophagus and the stomach. And in fact, if you've been looking at the Ackland videos, recall that he just calls the entire distal intestine the jejunoileum. He doesn't even make a distinction. And in fact, in one of the videos, he just sort of removes it and reorganizes it to suit his preferences. But in general, that's not something you'd want to do. About a foot long duodenum and about 6 or 7 meters for the collective jejunum and the ileum. The ileum is about 60% of that, the jejunum about 40%. Now, there are a number of anatomical differences. I think the way I would summarize this, because we don't have a lot of time to talk about the reasons for this, in general, the jejunum is a little thicker, and it's more extensively vascularized. For that reason, it tends to have a somewhat more reddish color. So it's a little larger, thicker, more robust wall, and tends to have a more reddish coloration due to the increased amount of blood, if not the extent of blood vessels. We'll talk about the distribution of blood vessels in just a moment. Now, there's reference here to the vasa recta and the arcades. We'll come back to that in just a second. I think we'll have some pictures that illustrate what those two terms mean. And then also note, rather important here, the ileum has a much higher concentration of lymphatic tissue than does the jejunum. In fact, in the ileum, we have a special name for the lymphatic tissue called Peyer's patches. Peyer's patches. But all of that lymphatic tissue belongs, and we'll have a graphic on this later, belongs to something called GALT. And you have all kinds of GALTs in your body. ALT stands for associated lymphatic tissue, so this is gut-associated lymphatic tissue. You have GALT, MALT, and a bunch of them. And we didn't talk too much about this when we were going through the peritoneum, but in reality, the mesentery that we're looking at here sort of begins in the posterior abdominal wall and then sort of fans out and then folds back and forth. But my point is, and my very sophisticated illustration here, is that the mesentery originates along a very small stretch of the posterior wall of the abdomen. And then it radiates, kind of like, what is that sponge called, a fan sponge or whatever, and then just radiates and then folds to accommodate the convolutions of the intestines from that original little segment there along the posterior wall. It's only about 15 centimeters long back there posterior. And of course, what we're looking at here, as we look at that greenish region, we're looking at that bifold of peritoneum that is important here because it contains all of the blood vessels, and if you notice the fatty tissue in there, but all the blood vessels, the autonomic innervation, lymphatic drainage, all of that is present. Of course, lymphatic drainage in this region is important not merely for immunological purposes. A lot of your fatty nutrients are taken into the lymphatics from what's called the lacteal of the mesentery. So there was an earlier reference to the vasa recta and the arcades. And the bottom image here, for example, it might be easier to make this evident. You can see the jejunum and ileum on the right. The portion of the vasculature, the blood supply to the mesentery or the intestine that you see here, so this thicker portion you see here, and you see in the ileum over here, those are called the arcades. And of course, they extend, branch, and radiate, articulate through the mesentery. Distal to those, and you can see these vessels are more or less perpendicular to the intestinal wall. These are called the vasorecta. So the arcades would give rise to the vasorecta, which actually perfuse the intestine. Now, that being the case, there are some subtle differences here. You'll notice that, in general, the jejunal arcades are, it's maybe not too clear here, but they're thicker but less abundant. So they're thicker but less profuse. In the ileum, the vessel is smaller, but they're, what's the word I'm looking for there? They have a higher relative abundance. They're more of them. They're denser in their concentration. And you can sort of see that here. This would be the jejunum at the top, the ileum at the bottom. Here's our arcade. Here's our vasorecta. And so you can notice that the arcades in the ileum are a little more complex. There are more levels of it, but they tend to be smaller. And then there are more vessels that make up the vasorecta. The other feature, I don't know if we'll have time to talk about this, but you'll notice as they've opened up the ileum and the jejunum here, how many more little corrugations or folds there are in the ileum in the jejunum than in the ileum. Those little corrugations or folds, I suppose, are analogous to the ruga of the stomach. We call them plicae circularis. They go by a variety of names. Call them, for now, we'll just call them plicae. Valves of Conaventes, it goes by a variety of names. In any case, notice they become far less evident. They almost disappear. And of course, they're really not. The morphology of the colon changes entirely, but the concentration or relative abundance of those plicae diminishes dramatically as we move distally. Let's see, I want to sort of summarize the blood supply. Let's do it this way. Let's just look at this picture and talk a little bit about the blood supply to the proximal and jejunal-ileal intestine. All right, looking proximally, what you'll notice is here's the duodenum here, of course. And extending from the celiac trunk here is the hepatic artery, common hepatic, which gives rise to this gastroduodenal artery right there. So that's the gastroduodenal. And then arising from that, things get easy at this point, there are two pancreatico-duodenal arteries. There's one in the front and one in the back of the pancreas. So you have an anterior and a posterior one arising from that gastroduodenal artery. And these supply, for our purposes, these supply the duodenum for the most part. Of course, the head of the pancreas too. But notice they hook up. They move right back into the inferior mesenteric. I'm sorry, the superior mesenteric. And you know the superior mesenteric also perfuses the remainder of the intestine up till about the descending colon. Venous drainage, we've already talked about the venous drainage. The venous drainage for this region is going to be into the superior mesenteric, the inferior mesenteric, and the splenic vein, keeping in mind that a great deal of variability. Lymphatics are generally into the superior mesenteric and celiac nodes, which are all sort of clustered right in here, into the inferior lesser curvature of the stomach. You've seen this illustration before. I don't know if you remember, but we looked at this earlier in the course in our overview of the autonomic nervous system. Now, this should be very evident to you. There's nothing here that you haven't grappled with already. You can see sympathetic and parasympathetic innervation, or at least the preganglionics and postganglionics. The only problem we had then, and I submit that we may still have with this illustration, are those purple fibers. What are those purple fibers? And somebody explain to me, what do we mean by a visceral afferent again? Afference implies what? Sensory function, but what makes this particular? So as you look at the fiber here, you'll notice what type of neuron is it? How would you classify it morphologically? All right, so it's a unipolar or pseudo-unipolar, but what is unusual about it anatomically? Well, its synapses, the synapse may or may not be. Where these things terminate is a bit of a mystery because of what they do. We'll talk about that in just a moment as I untie my shoe with my other foot. But they're running along the autonomic pathway. So these are sensory, these are arguably, and this is where it gets fuzzy, these are arguably somatic neurons that run along, in many cases, autonomic pathways, often the sympathetic. And that's why we call them visceral afferents. These are, again, from the morphology, you would assume that they are conveying some type of tactile or pressure sensation or something of the sort. But again, they're running along the autonomic pathway. So as a PA, and I guess just as a human being, what type of sensations? Have you ever had any sensations that you can reflect upon and share with the rest of us that arise in your intestines? Anybody want to talk about their intestinal sensations? Let's share. Well, how would you describe intestinal pain? Have you had intestinal pain of any sort? And sometimes you don't know if it's intestinal, it can be referred. Can you localize it very precisely in most cases? No. Most of you have sensations of pressure, distension, perhaps. So they're very vague, but I guess the point I'm making is that I think we can argue that there is some species of somatic sensation, poorly localized pain, which is usually referred to some other location, pressure. What else? Do your intestines ever itch or tickle? No, I don't think so. So it's a rather primitive type of signal, but in any case, to the extent that they're supplied to your brain, they're supplied by these visceral afferents. And again, if you want to spend a couple months of deep study, just research the anatomy and function of visceral afferents. I think you're going to be surprised that it's not as clear cut as you might think. But in any case, this is just a reminder that you need to be familiar with the general autonomic pathways that we've already discussed. And of course, this is a discussion of the function. We'll talk more about this in physiology as time permits, but in general, sympathetic signals tend to suppress GI tract activity. Parasympathetic signals, rest and digest, tend to enhance both motility and secretion. Now, we're going to talk more about these plexuses a little later, but we've already talked about the prevertebral sympathetic plexuses. For example, you should be familiar with the celiac plexus, the superior mesenteric and inferior mesenteric. So that's all that this is talking about. Parasympathetic innervation is chiefly vagal. We'll talk in the physiology about vagal reflexes. Professor Sparker will drive you crazy with her discussion of vagal reflexes. They're very important both in the thoracic and abdominal cavities. We'll talk more about that a little later, but that's all that this slide is referring to. We're looking, of course, at the colon here, the large intestine. So, of course, you want to be familiar with the various regions of the colon. You want to know which side of your abdominal cavity the ascending colon is located on, which side the descending colon is located on. Of course, this is the transverse colon up here. This region is called the sigmoid colon. We have an interesting little video we'll look at after the break that hopefully will delay your lunch. That's the sigmoid. Of course, you'll probably be involved in sigmoidoscopies and colonoscopies and so on. So you want to be familiar with that basic anatomy. Here's the rectum and anal canal we'll talk about probably next week. At least on Monday, we'll probably get to the anal canal. Everybody can, if you can wait to that point, if you can hold on to talk about the anal canal. Here we see the junction between the ileum and the large intestine. It's sometimes called the ileocecal valve. It's really not much of a valve. There's no substantive sphincter there. It just basically allows the chyme to move rather freely into this region called the cecum. And the cecum down here is this little sac, sort of inferior to the ileocecal valve, characterized by the presence of the appendix. So there's your vermiform appendix, which is arguably vestigial immunological tissue. Other features of the colon we should be familiar with are these. You can see these little chambers. The colon is broken up into these individual chambers called haustra. You can see the singular there, haustrum. And the margins or borders of each of those haustra consist of a ring of smooth muscle. So your colon is actively segmenting the chyme, breaking large segments into smaller segments by means of these very powerful haustral smooth muscle components. The outer region, remember we said that the muscular layer of the GI tract normally consists of a radial layer. That's mostly what these impressions are. And then there's a longitudinal layer. Well, that sort of changes a little bit in the colon. The outer longitudinal layer forms these three bands. You really don't see them here, but there are three bands of muscularis externa, the lengthwise, and these are called tinea coli. Tinea coli. So let's take a break there and we'll finish up our discussion of the colon.